welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hello, everybody. My name is Heather Howell, and I am a PGY2 emergency medicine resident at Memorial Medical Center in Las Cruces, New Mexico. And today I'll be presenting a journal club for the ACCP EMED PRN Journal Club series on late TNK administration and looking further into that. So the two objectives I have for today are to describe the current literature consensus that surrounds TNK administration for stroke, as well as evaluate the benefit and risk profile of late TNK administration for stroke. I have a few key abbreviations that I'm sure we're all very familiar with, but just want to put it out in the open. So for TNK, we have tenecteplase, TPA, we have alteplase, AIS is acute ischemic stroke, LKW is last known well, MRS is modified Rankin scale, and the NIHSS is the National Institute of Health Stroke Scale. So starting off with a refresher of acute ischemic stroke and what it is. So as we know, we have plaque buildup due to atherosclerosis that's happening within our arteries. And if it's happening near and around the brain, we can have ultimately a ruptured plaque that dislodges from the artery, and it's going to cause that thrombosis that ultimately causes a full blockage of blood flow somewhere near or around our brain. And that is going to cause ischemia and further tissue death and brain damage. As far as evaluating stroke severity and stroke disability, there's two main scales we see. So we see the NIHSS score, as mentioned previously, that really helps define upon presentation what kind of differential we're working up for stroke, like usually if they're coming in for an altered mental status or something, and we need to work up for that differential of a possible stroke. So this is going off of stroke symptoms. Specifically, usually our nurses help fill out. And it corresponds to what amount of brain density is impacted. Versus on the right, we have the modified Rankin score. And this is going to be one that's specifically used to help define disability. So as you can see, MRS score of 0 is no symptoms versus all the way down to MRS of 6 is death. Right below that of an MRS of 5 is a severe disability where they're essentially bedridden and need 1000% nursing care and attention because that's disability. So these are both ones that we can use initially to work up a differential of stroke and the impact that we have on brain density and disability, but it's also one that we can use further on or after the stroke to identify remaining disability thereafter. And now starting off with our treatment guidelines that were published by the American Heart Association in 2019. This gives us advice on what kind of thrombolytics or fibrinolytics we can consider for patients presenting with an acute ischemic stroke. So the first one recommended is alteplase, and that is recommended for mild and disabling stroke that has a last known well of less than 3 hours with a grade 1 recommendation. And then the others are ones where we can consider based on like timing or other drugs that are available. So we can consider alteplase if it's a mild and disabling stroke with a last known well of 3 to 4.5 hours, and that's a 2B recommendation. Or we can consider tenecteplase if there are no contraindications to fibrinolytic therapy with a last known well of 4.5 hours, also with a 2B recommendation. Furthermore, if a patient has a non-disabling stroke or no severe symptoms, you do not give a fibrinolytic, is what the guidelines say with the grade 3 recommendation. Now looking more at our fibrinolytics, where the star is for TPA or TPA analogs. So these are going to be our tissue plasminogen activators, and they're going to work within our cascade of plasminogen to plasmin to really help with the quick degradation and fibrinolysis of our clot that's present. The hopes with this acting super quick and dissolving that clot is that we prevent further tissue death and further tissue damage. Next, I just have TNK bolded since that will be the focus of our presentation going forward and of our journal article later on. So looking further at tenecteplase, it gained its FDA labeled indication back in February of this year to use for acute ischemic stroke. This is the dosing card recommended here. So max dose of 25 milligrams, and it's roughly used at a 0.25 milligram per kilogram dose bolus. However, because of the way it's administered and drawn up as a bolus to give an ease of administration, the manufacturers have created this dosing card, so it's an easier volume to draw up of like 3 versus like 3.14, for instance. Now, moving on to previous literature that exists within this group, we're starting off with a meta-analysis of alteplase timing. So this was a meta-analysis done in 2014 that compared 9 different randomized control trials or open control trials. Of note, these were all the trials that are available at that time and completed evaluating TPA. It enrolled over 6,700 patients, and the big thing we were looking at here was good stroke outcome, and that was evaluated at various times of administration. And we also looked at, for our safety events, incidents of hemorrhage and death. A good stroke outcome was defined as no significant disability at 3 to 6 months, but specifically our objective measure was an MRS score of 0 to 1. As you can see with the bolded numbers here, we did have some significance, which helped drive the timing of alteplase. So we see a good stroke outcome if TPA was administered less than 3 hours of last known well. So TPA had 33% versus placebo at 23%, so nearly 10% more. And if we had TPA administered within 3 to 4.5 hours, we still saw some significance with 35% achieving a good stroke outcome in TPA versus 30% in our placebo group. Then if it was administered after 4.5 hours, we don't really see a significance. TPA still had a higher rate of good stroke outcome, but it wasn't found to be significantly different than our placebo group. The other big thing I wanted to point out here was symptomatic intracranial hemorrhage was 6.8% in our TPA group, which makes sense compared to our placebo group at 1.3 since we are providing that fibrinolytic agent. And I will note that this was also not found to be different across different administration timings, and we saw no difference within our death group. Next, we have the Extend-IA trial. So this was a trial published back in 2018, and it is actually the trial that the guidelines use to consider TNK, and it essentially compared the non-inferiority and superiority of TNK to TPA. It was a randomized controlled trial that compared TPA to TNK in patients with a large vessel occlusion and were also eligible for thrombectomy, who also received drug treatment with 4.5 hours of their last known well. This study mainly assessed here the rates of reperfusion as well as their MRS scores at 90 days. For safety, we looked at hemorrhage and death incidents. Ultimately, we found one significant finding here with reperfusion greater than 50%, significantly higher in our TNK group of 22% versus 10% in our TPA group. With further extrapolation and analyses, this was found to be both non-inferior and superior to TPA with reperfusion. Then looking at the median MRS score, we did not see any difference 2 to 3 of TNK versus TPA, and we did not see any difference in intracranial hemorrhage. I will say for death, we had 10% in our TNK group versus TPA had 18%. It was not found to be significant. It was like almost there, confidence interval of 1 to 2.8, but ultimately found to have no significant difference between these. So this was an important trial since we know TNK has a lot easier administration feasibility than TPA. So this showed that it was safe and possibly better to use within our acute ischemic stroke patients. Next, we have the ACT trial. This one stands for alteplase compared to tenecteplase, and it was published back in 2023. It was a multi-center open-label RCT that was designed to detect non-inferiority of TNK to TPA for patients that were presenting with acute ischemic stroke within 4.5 hours of their last known well, who are also eligible for thrombectomy. The primary outcome here was the proportion of patients who achieved excellent functional recovery, and that was defined as an MRS score of 0 to 1 at 90 days. For our safety outcomes, we looked at, similarly to the other trials, death and symptomatic intracranial hemorrhage. The interesting thing in this trial, too, is that they divvied up their trial participants by TNK and TPA at 0 to 3 hours, as well as TNK or TPA at 3 to 4.5 hours. So we could really see if there was any difference as far as safety and disability. Also, nothing here is bolded because nothing was found to be significant. So this proved that TNK was non-inferior to TPA in achieving functional recovery and also did not have a big impact on safety outcomes or difference in safety outcomes. So this study was actually one of our big studies used to gain FDA approval to use for acute ischemic stroke last year. Now, switching gears to today's journal club, we're going to discuss the Timeless trial that was published back in 2024, and it is studying tenecteplase for stroke at 4.5 to 24 hours with perfusion imaging selection. As you can see from the previous literature we reviewed, the timing of thrombolytics was mainly studied within our alteplase group, and we have continued to extrapolate that information into our tenecteplase group since we've compared them to be non-inferior to each other, but we haven't specifically studied timing of administration within our TNK group. So the objective of this study was to assess if there was any benefit in administering TNK late, and that was defined as a TNK administration of 4.5 to 24 hours after the last known well. A big differentiator with this study was that the investigators looked at patients with specific large vessel occlusions. We'll touch specifically on what those occlusions were. And these patients also had to have salvageable tissue on imaging prior to administration of fibrinolytics. It was a multi-center study across the US and Canada, over 112 sites, with 4 of them being in Canada. So for the most part, this happened within the United States. It was a double-blinded randomized control trial. So this compared a placebo bolus versus a TNK bolus of 0.25 milligrams per kilogram. And lastly, I wanted to mention that the Timeless trial was sponsored by Genentech. However, the investigators went to lengths to remove Genentech from any bias or tried to remove any bias associated with their sponsor, as Genentech played no role within the study design, execution, or preparation of the manuscript. Furthermore, Genentech was not able to view any of the study results until it was published as well. For our inclusion criteria, we have patients were eligible if they're 18 years or older. They had to have functional independence prior to the stroke event. So that was defined as a Rankin scale of 0 to 2. They had to have a moderate stroke or an NIHSS score greater than or equal to 5. And these patients had to have no other contraindications for receiving TNK, like a recent surgery, blood thinners, recent trauma, etc. Occlusion had to be confirmed on imaging and shown to be in the internal carotid artery or the middle cerebral artery. The middle cerebral artery was further differentiated between the M1 and the M2 segments. And this is important as patients undergoing thrombectomy were left up to provider discretion if the occlusion occurred at the M2 segment. Lastly, the treatment drug was to be administered within 90 minutes of imaging that identified salvageable tissue as well as the presence of occlusion. The primary outcome assessed was the modified Rankin scale score at 90 days. Secondary efficacy outcomes included functional independence, defined as an MRS score of 0 to 2, if the vessel was recanalized 24 hours later, what reperfusion was present 24 hours later, and imaging proof of reperfusion immediately following the thrombectomy. Secondary safety outcomes are the same outcomes that we've been seen studied within the previous bodies of literature, which are death and incidence of hemorrhage. For statistical analysis, this was a 2x2 factorial design that allowed the study to assess several treatments together for effect based on protocols included. It was also an intention to treat protocol, so it tried to follow more closely what we would see in real life. It was powered to detect an odds ratio of 1.41, and that established that they needed to enroll 456 patients. The efficacy outcomes were analyzed in a hierarchical manner. So if one outcome was found to be significant, then they would move on to analyzing the second outcome, so on and so forth. It was not found to be significant, then they would not move forward with further analysis down the way of efficacy outcomes. And the investigators used a p-value of 0.049 to be deemed significant findings. For the protocols used, there was 5 different protocols as listed here, and this is where they use the 2x2 factorial design to allow for further analysis across these groups. So you could have just done thrombectomy alone, so that would be a consideration if a patient wasn't eligible for thrombectomy or for some reason they didn't do it, like if it was the M2 segment, up to provider discretion. Could be TNK alone or placebo alone, or also it could be placebo plus thrombectomy or TNK plus thrombectomy. For our study population, so we just met power by enrolling 458 patients from March 2019 through December of 2022. 228 of these patients were randomized to receive TNK, and 230 of these patients were randomized to receive placebo. Comparing patients across treatment groups, they were pretty similar. I just wanted to point your attention to the median duration as it was pretty expedient. So patients' last on well was about 12 hours between the groups, which was very similar. But the drug administration occurred 13 minutes thereafter before undergoing a pretty immediate thrombectomy about 15 minutes later. So it begs the question, in my mind, of feasibility across the health systems if people and health systems can actually achieve this quickness. I would also like to point out majority of these patients did end up undergoing thrombectomy, with 25% of those that did not undergo thrombectomy, mainly due to the provider discretion at that M2 segment occlusion, if there was clinical improvement prior to thrombectomy, the clot if it was inaccessible during thrombectomy, or if no clot was identified during the thrombectomy. So overall, the reasons that they did not receive a thrombectomy were pretty similar across groups, besides no clot being identified during thrombectomy, where I did not identify a clot in 10 of our TNK receiving patients and only 2 of our placebo receiving patients. For results, starting off the primary outcome, looking at our median modified Rankin scale at 90 days, they were pretty much the same across groups, was not found to be significant. And as you can see from the image, a good majority of these patients had MRS scores less than or equal to 3 between the groups. So that did show a pretty good response, but not very reflective of a benefit of TNK or not. Next, for our secondary efficacy outcomes. So as I mentioned earlier with this hierarchical assessment of the efficacy outcomes, they didn't do formal analyses with p-values or anything, but they did do odds ratios. So functional independence was similar between the groups. Reperfusion was similar between the groups, but we did see a little bit more success with recannulation at 24 hours in our TNK group at 77% versus 64% in placebo, with an odds ratio of 1.89. Now, for secondary safety outcomes, we didn't see any difference, and they did not provide any odds ratios or p-values here of death at 30 days, death at 90 days, or the incidence of symptomatic intracranial hemorrhage. Although you can see the intracranial hemorrhage was seen to be a higher incidence in our TNK group, but it was less than 1%, not found to be significant. So as far as strengths and limitations, the strength obviously is that it's a randomized placebo-controlled trial, and they did take a lot of steps to minimize sponsoring bias. So I do think the authors did a lot to try to minimize as much bias as they could based on what the study was. They also included patients who underwent thrombectomy as a standard of care versus just looking at thrombolytics. So in a sense, this can blur how effective like the thrombolytic is, because we're not assessing just thrombolytic success. But on the other hand, we want patients to undergo thrombectomy still because it's a standard of care, and that's what they'll do within the general patient population. Also, it was an applicable and useful primary outcome study looking at the modified Rankin scale versus like reperfusion is great, but does that translate to improved disability markers? So it leads to actually like valuable information to the patients. And as far as limitations, so as I mentioned before, they did a limited analysis on secondary outcomes. So we are not for sure if they were very significant based on the p-values not being reported or analyzed. With having the provider discretion to conduct thrombectomy in our M2 segment, it really allows for variation and bias to be introduced into the study. Many patients already were also in a comprehensive stroke center, which really allowed access to the quick thrombectomy, like I showed before, happening within 15 minutes of receiving the thrombolytic. How generalizable is this to the our overall population is questionable, since we don't have comprehensive stroke centers everywhere and in healthcare deserts. So I wonder what the difference would be if patients had an extended window from when they were getting thrombectomy. And then treatment was limited to specific occlusions. So only limiting it to the M1 and M2 or intracerebral artery occlusions doesn't give us the ability to extrapolate this information to other occlusions like distal occlusions or minor occlusions, which in the grand scheme of things, these large vessel occlusions are going to be the ones that are the most debilitating. But it would be interesting to see how this information can be extrapolated to other strokes where we do consider and use TNK or thrombolytics within them. My overall conclusion of this study is that TNK does not improve disability status when administered greater than 4.5 hours after stroke symptom onset, but it also does not increase hemorrhage risk or death when administered greater than 4.5 hours after stroke symptom onset. As far as what's next, applicability to practice, I think the results really support current practice recommendations. So that's really good. We're not seeing anything life-changing. You see that we're going on path with safety and efficacy standpoints within our guidelines and current practice recommendations. The interesting thing I thought here is that maybe this could be an option to consider in the future with patients that have an unknown last known well, like if they're like they went to bed fine and they woke up in the morning with these debilitating stroke symptoms. If they do have salvageable tissue on imaging, maybe it is something to consider in this patient population since you really have an unclear amount of time on when that last known well was. And we do see that it is safe to administer greater than 4.5 hours. We just don't see as much of an efficacy benefit there. So maybe it would be something to consider when we're really like up in the air on when it happened. As far as what's next, I would be curious to see if similar results were reflected if we studied this in distal or small vessel occlusions. I would also be interested to see if similar results were reflected if it was done outside of these comprehensive stroke centers, where we're seeing a longer time from thrombolytic administration to thrombectomy, if that has any impact on our modified Rankin scale score or death or intracerebral hemorrhage. So that was all I had today, taking our deep dive on late TNK administration, and I appreciate your time. If there's any questions, I put my email on this slide, heather.howell@lpnt.net. Feel free to shoot me an email. Thank you.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.